two oldest of the family just turned 30.
Let us convene this meeting of the Indian River Hospital District here in the Indian River County Commissioners Chambers, 4 o'clock, invocation. Frank.
Thank you, Mr. Chair. If everyone could bow their heads, please. Gracious God, we pause at the start of this meeting to acknowledge a profound loss in our midst. Our trustee, colleague, and friend, Paul Westcott, has lost his wife, Kimberly, after a courageous battle with cancer. We hold Paul and his family in our thoughts and prayers today and in the days to come. May they be surrounded by comfort, strength, and peace in the days ahead. May they feel the support of those who care for them, even in moments when words fall short. As we continue the work before us, help us to do so with humility and compassion, mindful that behind every person, patient, every role, every responsibility is a human life shaped by both joy and grief. Lord, please grant Paul and his family comfort, courage, and healing, and grant all of us the wisdom to lead with empathy and care for one another. Amen.
Amen.
Thank you.
And for the budget.
Of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Before we move ahead with the agenda, I'd like to call on our trustee, Paul Westcott, for words.
Thank you. Yeah, I've been thinking about how to discuss it, and my wife Kimberly and I have been married. It would be 35 years in in March. She would be 60 in April. Her passing, obviously very early. We had the help of hospice locally, and it was for as difficult a time that was. If you have to go through that experience, I don't think it could have been better for us. She was undoubtedly the strongest person I've ever known. She's just a wonderful mother, wife. I was joking with someone earlier that whenever I had those frustrations that you have in marriages, it was without a doubt because she was making me better, no doubt. The decision was made by her very courageously, and it was an expression of her faith, quite frankly. She was forever hungry to know God and know more about God and have a personal relationship with Jesus Christ, which she did. And that was clearly evidenced at the end. She made a very clear decision regarding the management of her pain and her medication. It was very minimal. She wanted to be present to the end, and which created a beautiful opportunity for me and my 3 children to be with her, comfort her, doing the things that she needed us to do for her and keeping her comfortable. Hospice was very helpful and cooperative in terms of answering our wishes. And at one point I had shared with her that a friend of ours had expressed that she was hurting for her, and Kim's response was, well, I'm not hurting for me. And that was comforting for us in terms of expression of her faith, and that makes all the difference. She died Saturday morning very early. Friday evening there was a moment in the low light where I saw my bride. She was comfortable, relaxed, and God gave me a vision of her, of our early days. She'd had one of the tumors that was on her face, and I have no memory of that. I just recognize that as a gift from God, that it was a blessing time together. We received really compassionate care that I can't say enough about. And I just want to thank all those that were involved with their treatment. and those of you that, all of you that have been expressing your concern and your prayers for us. I appreciate that. Thank you.
Well, on behalf of the board, our thoughts and prayers are with you and your family.
Thank you.
Have a good time, Paul.
And I couldn't be here if I didn't have a knowledge of her destination, without a question. That makes a big difference for me and my family. Thank you.
Thank you very much. We have a consent agenda with minutes from chairman's meetings in November 3rd, November 19th, and regular meetings to November 20th. We had a December disbursement of $1,710,615.
Move approval.
Second.
Any discussion? Any changes in the minutes? Hearing none, all those in favor say aye.
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 Okay, let's move on to the chairman's report. There's a lot of activity. I'd like to congratulate Frank and his staff for moving forward with the maternity labor plan and contract with Cleveland Clinic and Indian River Hospital. That was a major accomplishment. Congratulations. Similarly, I'd like to congratulate the process related to the 10th Street property and the role that Karen has played in helping organize that. Zoning may still be an issue. We're not sure related to what is medical care, but I think we're heading in the right direction. Thirdly, I think the VNA pool property request has been very well handled by Jennifer Pesci, our legal representation, and others. Still, many more issues arose than we anticipated. So we're kind of in a delayed holding pattern with that at the present time. Fourthly, we'll hear today about the VCOM lease with future amendments being presented here today. And an extension of the lease or understanding where the state of Florida and a certificate of need with respect to a school for medical students is still out there in the unknown area of legislation. But VCON is moving forward with getting that approval. Notification and support is coming forth from our hospital district related to this and the potential future down the road for primary care. I have to remind everyone that Cleveland Clinic is a closed hospital staff. I'm practicing orthopedics. That's great, but unless I can operate there, but I can't really be on their staff until I'm invited. In that regard, Frank finally gave an excellent presentation to the Cleveland Clinic Indian River Board of Trustees, detailing exactly what the role of the our district is with respect to what Cleveland Clinic does, the lease of the facilities, support of their programs. There was a number of questions which he and I answered for them. So that concludes my chairman's report. I'd be happy to answer any questions.
Mr. Chairman, because you serve, as our chairman, you serve on the board of directors. I've kind of figured out, do I want to save this to the end? I think at the beginning of the meeting, we have more people interested. I think it's worth noting now. And that is, our hospital was given a 5-star rating by Forbes, only one of 11 hospitals in the state of 350 total. I think it's noteworthy. And I would like to see you or have a letter from us, not to Cleveland, acknowledging the leadership that we've been experiencing here and thanking them for that leadership, with the PS to not promote him away.
The current lead, well.
Yes, Dr. Rothman in
Yes.
particular. So no, I just think it's really good news. And you know, if you've been paying attention, there have been times in the past where maybe I was critical of Cleveland Clinic. I don't get complaints anymore, and I think it has a lot to do with the decision that was made to promote Dr. Rothman from our hometown. He knows us, and I want to make sure that we recognize the wisdom in that decision as best we can and encourage them in that regard for us. Thank you.
I've spoken with Dr. Rothman and also Michael Hammes, chairman of the board, congratulating them on the Ford's recognition. Just another note, they continue to, particularly through Dr. Rothman, move into the community and bring community physicians into the hospital itself, both in operations, but, with the ability to perform different procedures. But also, they've just hired or brought in a local orthopedic group to expand their orthopedic practice, which is another very positive move. So they continue to move forward. And again, Dr. Rothman has brought perhaps 125 private practice physicians into the Cleveland Clinic a team, so to speak, and that's a very big accomplishment.
Mr. Chairman,
Sir.
may I make a comment? Thank you. I just wanted to clarify for the record. I heard you say that Cleveland Clinic has a closed medical staff. I don't believe that's completely correct. For instance, I am an independent physician. As you know, that I am a per diem employee by Treasure Coast Community Health and still see patients there, but I am a member of the medical staff, as are surgeons at Vero Orthopedics and several of the cardiologists, et cetera, in the community. So I just wanted to make that clear.
I assumed that they were similar, Chuck, to a Mayo Clinic, and that if you're part of the Cleveland staff, starting down in Weston and moving north, that was, people, as I said, are able to come there and operate and do other procedures, but they're not formally, that's my understanding, but thank you for the correction.
Yeah, I just wanted to make sure that for the record, the community knows that there are physicians on the staff that are not employed by Cleveland.
Thank you. Okay, anything else? All right, let's move to our district council report.
Thank you, Mr. Chair. Again, just a reminder that our monthly meeting packets now contain a copy of Form 8B, the statutory memorandum of voting conflict. So that is there as a resource for trustees. If they do deem that a conflict has arisen, we'll use that form as we've explained at prior meetings. In addition, the attorney's overview is also included with each monthly packet and is included again with this month's packet. This contains a very good summary of the board's practices and procedures in conducting our public meetings, and specifically also sets out the parameters for public comment. All public comment shall be heard in accordance with the district's practices for calling for and receiving public comment. And there is a 5-minute cap per person that is going to make public comment. So that is all spelled out there. In addition, as far as business that we've been working on this month, we've prepared for your review and approval, as we discussed at yesterday's chairman's meeting, a proposed lease amendment by and between the district and BCOM for the lease of the Human Services Building. This extension was granted at the October meeting and gave until approximately January 9th of 2026 to adopt this, so that we have had some meetings with them yesterday. They've been here in town and on site at the Human Services Building with Frank and other district staff. And we have brought that forward for your review and consideration. And we'll probably, I believe we'll address that under unfinished business later on in the agenda. So that has been circulated to you, and we'll bring that back a little bit later in the meeting for your review, discussion, and then approval if that's what the board would like to do. With regard to the VNA matter, they had previously brought forth a request to allow them to access the existing retention ponds on the land the district owns adjacent to the parcel that the VNA purchased from the district. And as our chairman just mentioned, this is a little bit more involved than it was initially thought to be. So we have hired our own engineer to review and analyze the matter on the district's behalf. We did have a meeting approximately 2 weeks ago as a group with the council for the VNA, some board members for the VNA, staff for the VNA, district staff, district council, our engineer, their engineer, received a little bit more information that we're continuing to evaluate. We've requested their plans so that we could review those in light of what the district's easement agreement attached to the 2018 and then amended 2021 lease indicate. And so we're not ready to take action on this at this time, and we'll be bringing it back for your review and consideration in the first quarter of the new year. We issued, as we do every year, a response to our auditors, Jacoby and Hanley. on November 26th in response to their request for information regarding the district's audit of financial statements. This is something we're asked to do every single year, just confirming that there's no open liabilities known to the district. So we've provided that to the auditor at their request. And at the board's request, research has been conducted and circulated on the following topics: the district's ability to impose residency-based restrictions on service eligibility and interpretation of and parameters around the district's authority to exercise eminent domain pursuant to the special act, and whether the district is limited in directing patients to specific medical providers. We have circulated that to each of you. I haven't received any feedback or comments, but certainly we are available to speak with you on a one-on-one basis if you have questions about that, or if anyone didn't receive it or missed it, let me know and we can circulate it again. I know this is a busy time and we've had a lot going on as a board. Are there any questions I can answer at this time?
Thank you very much, Jennifer. Any questions? Okay, great. Very nice report and always very concise. Let's move on now to our Executive Director. No, sorry, let's move on to Michael Kent, our Treasurer. Financial statements.
Thank you, Mr. Chairman. 2 months into the hospital district's 25-26 fiscal year, I am very pleased to report that the district's financial situation is quite strong. To review the November financials, please turn to the last 4 pages in the financial section of your board packet. 4 pages from the end, you'll find the 1-page investment and cash snapshot. At the top of the page, you'll see that as projected, the district has received $8,481,722 of ad valorem taxes in the last month, which represents 38.1% of our budget. If you recall, we had 0.7% at the first month, but I referenced this is big. It'll be big in December, and we'll have almost all of it by the end of January. Moving to section 1 of the snapshot, you'll see that the district's U.S. Treasury holdings on November 30th, our T-bills totaled $7,612,751. That last column to the right shows the staggered maturity dates of the T-bills that we now hold, and they are earning an average interest of 3.63%. That next section 2 details the district's holdings in our money market account, the preferred deposit pool, and you see that at the end of November, it held $3,228,877. It was earning then 3.78%. And then section 3, as always, shows the district's local operating accounts at Seacoast, and they were holding $3,148,919. Altogether, 2 months into fiscal year 25-26, the district's investment and cash holdings total $13,990,547. And as is noted in Mr. Isley's report, 98.7% of all of that, all those holdings, they are in some form of investment. If you turn the page, we'll be on the first page of the year-to-date expenses versus the budgeted expenses spreadsheet. Though all programs are, as you know, reimbursed on a fee-for-service basis, at 2 months into the fiscal year, you might expect expenses somewhere around the 16.7% of the approved budget. And you'll note that in the first 2 entries of the spreadsheet, the low-income pool, there are no payments. It shows 0%, and this is typical. Those will come in kind of mid-year, and that's the norm. You'll also see, if you start scanning TCCH and Whole Family Health, both have a couple of programs that appear to be running hot. This is true of a few other programs as well. As we talked about a little bit last month, staff will continue to watch these programs and follow up with these community partners if the trend continues. On the middle of the last page of this spreadsheet, you will see that the total for all program expenses at the end of November was $3,636,259. and that represents 16.4% of the approved total program budget. The bottom half of the last page, as always, shows the district's administrative expenses. The clear standout in this section is the 521.6% for licenses and fees for the 10th Street properties. I've had a meeting with Frank and Kate about how we're capturing and reporting expenses for the three main properties that we hold. As there is some inconsistency for the district's three properties and how they're, we're going to meet again in early January, and we're also going to include in that meeting our friends at DeSalvo Tax and Accounting to talk through. There's a few things that we want to deal with. Nothing to panic there about. That's a big number, I know. You can see that total admin expenses through November 30th totaled $236,363. That equates to 15.6% of the approved budget. So combined total program and administrative expenses totaled $3,872,622. And that is 16.3% of the budget. And finally, as a point of comparison, at this point, last fiscal year, total expenses were $2,847,120, which was 14.1% of the last fiscal year's budget. At yesterday's chairman's meeting, I reported that the Finance and Audit Committee met in November, where we spent much of the meeting reviewing the three policies that were discussed yesterday. One was approved. We're looking at another one shortly. Moving forward, and this kind of came up prior, but I just wanted to make note, between the chairman's meeting or workshop and our regular monthly meeting, I will make sure going forward to spend a little bit of time, nominal, just to provide you updates on the F&A committee meetings. And Kate, as you saw in this month's packet, will begin including all approved meeting minutes. I say approved because in fact, we did meet in November. That was the meeting I referenced yesterday, but the committee hasn't met again to approve those minutes, and that's why they weren't included. And our next meeting is coming up in early January. With that, I think I've finished. I'd be happy to address any questions trustees might have.
Yep, thank you, Michael. I appreciate you addressing the fee-for-service areas that look like they're running way ahead of what was planned and budgeted. For the administrative expenses, and perhaps Frank can address this, I also saw that dues and subscriptions and professional services legal were running a little bit ahead as well. Is some of that timing, Frank?
It is indeed. It is indeed, Dr. Mackett.
Yeah, that made sense to me that we
One
might
time.
have licensing fees, we might have taxes that are due, et cetera. And I wouldn't expect those to be peanut butter spread across the entire.
You won't see that, Dr. Mackett.
Yeah. One other question I had, I was happy to see that we put the depreciation for the 10th Street building in the balance sheet, and we've also budgeted all of the depreciation on the P&L, but I didn't see that any was booked last month or this month.
That's part of what we're going to talk to DeSalvo about as we go forward.
Okay, great, because those are non-cash.
Yeah, I mean, you could do the math,
expenses that we
divide it by
should track.
Exactly.
Yeah.
Exactly. That's the point.
Great, thank you.
I had a question, Michael,
Sure.
related to Cleveland Clinic and River Hospital. And their mental health and substance abuse program. There was
Mhm.
some indication that they had not needed our funds, we're not using them, but you're still counting them. So where are we with that, you know?
You know, I don't know if the total, I don't know if we were billed for anything in the last month or not, because I didn't compare the number against last. I'm looking to Kate. I'm not sure if there will be no expenses, there or not.
I
So
believe
I'm
that
gonna-
was only for last fiscal year.
Correct.
Shannon could probably speak more to that. So it was just for the last 2 months of the last fiscal year that they did not charge us for that program. It
Okay.
was part of their approved budget for this fiscal year, and beginning in October this fiscal year, they did
Went
begin
back.
charging for that program again.
Okay.
It was
Yes,
a
sir.
total of about $124,000, $125,000, which they did not
They
charge
didn't?
us for last.
Last fiscal year,
Correct.
correct?
I just thought that was remarkable turnaround considering the cost of behavioral health and other issues. So, okay, thank you. Okay, any other questions for Mr. King? Pleasure. Very nice work as always. Thank you.
Thank you, Mr. Chairman.
And now we'll turn to our executive director, Frank Isley.
Thank you, Mr. Chair. So everyone has a copy of my report and it was quite lengthy. There's one item that I want to just talk through and just hit the highlights. This is the first year, because effective December 1st of 2025, Florida law requires each special district to post an annual report on its website, which we did. And the report has to describe the performance measures, the standards used by the district, identifying the specific goals and objectives that were achieved, and make note of any goals or objectives that were not achieved. So we did post our report, and I just want to hit the highlights. So in our first year of our 5-year strategic plan, our measurable progress has been achieved across access to care and workforce capacity goals. The number of full-time primary care providers participating in Medicaid increased by a count of 6 providers, which represents just under a 16% gain. And this exceeded our annual benchmark. Similarly, the number of full-time mental health providers increased by a count of 10, which was just under a 17% increase, also surpassing our 1-year targets. Now, access to care for uninsured and underinsured populations also improved. The number of qualifying patients served increased by 6.6% year over year. And the encounters among fee-for-service community partners rose by 45%. And if there's any questions around that large increase, Caitlin would be happy to answer them momentarily. Preventive health and substance use reduction initiatives are in their baseline year. So due to a data lag, outcome comparisons for 2025 are not yet available. However, the baseline data show mixed but encouraging trends, including reductions in preventable hospitalizations for diabetes and congestive heart failure, as well as a decline in overdose-related ER visits, emergency room visits. These baseline measures establish a foundation for evaluating future reports once the data comes in. So that's all. That's the only item I'm going to mention in my report. We've got a few items that I'm going to ask our staff to talk about. Let's start with, trying to remember who we're going to start with. Jenny. Let's start with Jenny. And 1, 2, 3. Okay. Let's start with Jenny. Jenny, if you please. Thank you.
I just wanted to give you an update on the program and service transition process that we implemented in September of 2025. This was where we outlined the plans to work with our community partners during the process of fee-for-service and for the transition and sunsetting. So since my last report, the staff has completed phase 2 of the program and service transition process, providing a letter of understanding to our community partners for clarity on the transition terms, timelines, and reporting responsibilities. We are currently in process with phase 3, which is to support our community partners to help ensure a smooth transition to newly adopted fee-for-service model. District staff are actively managing the transition through direct one-on-one engagement with community partners as they shift to the fee-for-service model. The focus remains on identifying unintended impacts, ensuring continuity of services, and maintaining fiscal oversight. As anticipated, with the implementation of the new fee-for-service structure, some partners have significantly underestimated projected encounter volumes, resulting in higher utilization than expected. Therefore, that's why the budget is a little bit heavy on already. Shannon and I are meeting one-on-one with our partners to ensure that payments align with actual service delivery, additionally reinforcing consistent encounter definition and reporting of encounters to prevent any confusion moving forward. Follow-up meetings are scheduled after processing our January invoices, which reflect December, which is the first quarter, to assess remaining budget balances, evaluate utilization trends, and decide if further adjustments are necessary. This will also assist them in their encounter projections for the next funding cycle, which we're about to start in a few months.
Thank you.
May I ask a question?
Sure.
So the encounters are lower than what they no,
The encounters are higher than
higher, sorry,
projected,
yeah, I went
yes.
the wrong way.
Mhm.
Higher than, are the actual numbers higher, or is it their projection, you know?
Well, if you recall, and you know, you didn't work with the applications, but the encounters, the fee for service rate was projected based on how many encounters they projected
Correct.
and their overall budget.
Mm-hmm.
So what we're finding is that because they're submitting invoices for more encounters than expected, they're going through their funding faster. So the rates kind of may not be 100% correct because again, that was based on their projected encounters.
So they are indeed seeing more patients.
Correct.
They just, you know, their crystal ball was fuzzy when they,
Well, and of course, because this is the first time that
Right.
we've gone to this model, we tried to define encounters, but maybe the definition wasn't clear.
I was
So
just trying to see if it was a math problem or if it was that they actually are seeing more
it's
patients.
probably both,
Okay.
it really is probably both.
Okay.
Now, let me jump in for a minute and just add that this is not unexpected.
No,
We planned on this. There's certain services that were very easy to anchor in solid rates and be consistent. But many of the programs and and the other thing is, we had clear counts from some of the key organizations of encounters from prior years. But for most of the programs and services, we had no idea, nor did they have any idea what the volume of encounters was like. So we're setting all that up right now. And I feel very confident on our process and the way that Jenny and Shannon and the team have been working with our community partners that we're going to have this all dialed in.
please know, I wasn't questioning, right?
Oh,
This
no.
was from the heart, just understanding
Yeah.
what's going on in our community. So,
Yeah,
okay.
yeah, so it is.
Mr. Chair. So just to go on off what was just discussed, so a program that used to be funded grant-like, they put a budget together and that program cost 200,000 for the year, let's say. And they had done their budget and they know that's how much it's going to cost them to provide that service. And that's what we used to just provide them on a 1/12 basis. So now that they have done it in the fee for service and we're seeing this situation, and it's not just one, I think it's several, are most of them that you're seeing this in are the ones that switched from program funding to. So what happens when they get to the point of they've moved through their funding that they said they needed for this program, but now it's 6 months into it and all of the funding has been used up?
We're not letting that happen. And that's why we're having these
Okay.
aren't just quarterly meetings. These aren't even monthly meetings. There's emails, calls, and meetings happening constantly. They are working feverishly, dialing all this in. And once we have a baseline this year, we'll know exactly next year, if you're going to ask for a 20% increase in funding, we'd expect the encounters are going to be increased by 20%. But we
The
had
cost is increasing.
no question. The cost is a component of it too. So maybe the cost is 8%, the volume increase is
Right.
10%, and there's 20%. But the key thing is that we are going to understand, and they are going to understand the amount of encounters delivered. We're not going to say, okay, you're doing the same volume you did last year, but because we increased the fee for service rate or we picked this arbitrary rate, you're going to go through your money in 6 months. We're
Right, well,
not
then
doing
the
that.
concern was is that at 6 months, will they come back and say, ooh, I need more money?
Right,
But
right.
they set their budget originally, so, okay, I just,
And that's why we picked the first quarter to kind of meet with them so that we can see the trends and dial it back.
got it. Thank
Get it
you.
worked out.
Just in hearing this conversation, and it's something we've touched on before, my concern in hearing cost increase, I want reasonable fee for service that we're driving, okay? If I'm an entity and I'm not being careful, my costs are going to be going up. I want to make sure that we have some calculus in this process, that this is reasonable fee for service, not just we're paying the bill because we're given the bill and we're accepting the rate, but we have some conversation on what that rate should be.
We're setting it.
Okay.
We're
Just
setting
want to
it.
make sure,
No
because
one's
when I hear costs, I just want to make sure that
No, we're setting
that
it.
it's being anchored in a thoughtful, fact, evidence-based fee for service that we're setting. Okay.
Could just clarify that too. When we met with them in the initial meeting, you know, we recognize, they recognize sometimes the fee for service was just out of whack. It was way too high or way too low. So we looked and researched what those average costs are, and that's where we base those costs for. Connor.
Thank you.
Mr. Chairman, if I may, I almost got into some of this in my report and just decided, you know, let's wait for the quarter to be over. I was thinking about this myself, and I'll throw out 2 or 3 related issues. One, if you remember in those last days when we were approving budgets this year, some of these programs that we're talking about had asked for really significant increases. One of the things that I was doing as treasurer was just saying, let me project. We're not through the year yet. We're 9 months in by the time we made our decisions, but projecting where they were likely to be. So we were weighing it against how they were doing maybe in that last quarter. I'd always look at that too, just to see if things are ramping up in the last few months. So that was part of that's just another variable in a brand new process. And the other thing actually was said, that's been on my mind, and it's been said before and got said yesterday at the chairman's meeting. I think Paul is the one who said it. We're here to serve those uninsured and underserved, that ALICE population. And if, you know, we've got an established rate that we feel good about and they're showing up, you know, we're very likely to go ahead and say, yeah, we're going to pay more money to agency A for program B because they're doing exactly what they need to do. But when we do that, as was said, where are those dollars coming from? Out of our reserves. Now, they're nominal generally, but they can ramp up. So there's just a lot of variables in this process. And I think because we've gone to the fee for service, we got to live with it for this first year. There are going to be some glitches along the way. But I've said last month and I said today, and then you verify you're already on it. So it's not like we're taking any of this for granted, but it's going to take some time.
Yeah, Mr. Chair, if I may just add one more comment that I think may help. So right now we have 2 months of data. Once we have 3 months of data, with 1 quarter, we'll be able to project forward, get a sense of what the encounter volume will be. In addition to that, just to account for the seasonality and the snowbirds and all that, and what's going to happen potentially after December 31st with the exchange and insurance, is we'll do a trailing average, 4 months, 5 months, 6 months. And so we'll be able to get a really good projection and settle into those fee for service rates.
Okay, very good discussion.
So if I may, next, I've got Shannon up, if you please.
Yes, thank you very much. So I wanted to provide an update on the work that we are interested in pursuing with Jordan Flick of the Flick Framework for Grant Opportunities for the district. Currently, as I'm sure all of you are aware, the federal budget cycle is yet to be determined, with a finalized budget and potential grant opportunities to become available in January 26. So to continue advancing the district's grant strategy during this period, staff has asked the Flick Framework to conduct a retrospective review of prior year grant opportunities for which the district would have been competitive. This analysis is intended to serve as a proof of concept, demonstrating how potential award ranges, likelihood of success, and overall return on investment can be evaluated before pursuing future grant opportunities or contractual engagements with the FLIC framework. In parallel, staff has discussed the potential use of legislative appropriations as an additional funding pathway. Legislative appropriations are a time-limited, project-specific funding mechanism that differs from competitive grants and may complement traditional federal, state, and foundation funding strategies. Staff has communicated that no commitments have been made and that any future engagement would be subject to board approval. The consultant is currently outlining potential options for collaboration in 26. Once the grant landscape becomes clear and the proof of concept analysis is complete, staff anticipates returning to the board with findings and options for discussion, likely in early 2026. Based on prior funding cycles, it's reasonable to anticipate a limited number of viable grant opportunities in 2026 across federal, state, and foundation sources, with a strategic goal of securing a few awards aligned with district priorities. This phased, data-informed approach allows the district to pursue grant funding strategically and non-competitively with community partners. It demonstrates prudent stewardship of public resources and positions the district to respond efficiently as new funding opportunities are released.
Thank you.
Thank you, Shannon. And just not to put you on the spot, I know we just talked about it in my office without any specific plan, but it's too early to get into the detail that we have because we have to go through it and analyze it and do some projections. But can you just remind the trustees what some of the ranges of the document that we just looked at from Jordan, what the ranges were in terms of funding, what our 75% chance of securing funding for X amount? Can you speak to what those X amount ranges were like to which we'd have a 75% chance of securing?
Yes, so the low end of a 75% chance of securing number would be anywhere from about $475,000 to $500,000 for one opportunity. There's several opportunities that are higher, the high end range being closer to $1 million, but trying to project more moderate, reasonable numbers so that hopefully we can overachieve is what we're aiming for.
Thank you. I appreciate that. If I may, Caitlin, if you would, please.
So I actually have two different updates. First is the,
Put your mic
is it?
closer.
Okay.
And also Jennifer too.
Why?
All right. So I have two updates. First would be the annual survey is coming up again. So we've gone back and forth with Clearview over the questions. Obviously, we're not looking to change the question list very much because the whole point is to get overtime data. So you don't want to be messing around with them too much. So you get consistent information. We did go through and make a couple adjustments. Mainly, it was just to expand some questions because we wanted to see how parents with children also felt about their care access. If you remember from last year, that was one of the groups that they found had more concerning responses was parents with kids. So we've picked a few questions. There's going to be a subset. So they'll ask up front, do you have kids that live at home? And then if they say yes, to some of the questions they'll ask for themselves. And then also, how do you feel about the care for your children? How do you feel about access to care for your children? So we're going to get some like pediatric centric data as well. And then just like last year, we're going to have them do a more deep dive into the Medicaid and uninsured population, just so we can kind of focus in on that as well. So I'll be sending the updated list of questions to you guys probably tomorrow. And then if you guys have any feedback, just let me know. And then we're looking to field the questions in early January, with them coming to report on it either at the January meeting or the February meeting. I think we're going to try and do the January one if we can fit it in. So any questions about the survey? Okay. All right. So next thing would be the dashboard. Okay. Yeah, it's working. All right. So, the new dashboard that I created is now up on the website so that anyone can look at it, any members of the public. Just a reminder, it's under the impact tab and the healthcare needs data. So all three of the different dashboards that I've created so far are all on one page. The survey one, the first one that I made that has more general county information, and then the new one. So I'll go ahead and put it full screen. So as we've discussed, we're on month 2, so it's not going to be, this line chart, maybe a little bit better than it was last month with a singular dot. But so we're going to start seeing some trends over time, which is going to be good. Again, we can filter anything by the different agencies, by program, by date, by category. So it will be good to see different trends over time, especially with the different categories and agencies. And the zip codes will also automatically filter. So you can see where more people are receiving dental care or OBGYN services or the primary care. And then we are tracking the unique individuals as best as we can, because I know that's something that we've been really interested in knowing, and it was hard to do last year without everyone being fee for service. So we're finally able to track all of the unique individuals. I've assigned everyone a unique identifier, so it's all anonymous as well. There's no personal information being shared or input into this. So as it stands, only on month 2, we've already got almost 8,300 unique individuals that we've served, which was a lot more than I expected, honestly. So it's pretty impressive with almost 42,000 encounters. So it's looking like month over month, if we're going to have about 20,000 encounters, it's going to be quite a lot by the end of the year. And as Frank said, after a couple months, we could probably look into doing some projections after we get a little bit more data. Potentially could, project how much we're going to be at the end of the year. And then the second tab is our budget. Again, now we've got 2 months on there, so it's not just one bar. You can see all of the agencies that we've kind of discussed that are trending higher, usually because their fee-for-service rate maybe needed to be tweaked, or just because they're seeing way more people than they actually were anticipating. So with this, you can sort by the percent of budget used. That way, if you want to just identify the people that are at the top, you can open it and see specifically program rather than just the agency. And then on here, we've got the goal, like Michael said, it's 16.7%-ish if we were doing a flat like 1/12. So overall, we are right around on track, but there's a lot of variability with the different programs. So, and then this last chart here shows what each agency would be if they were doing a 1/12. So you can kind of break it out month over month. So over time, we'll be able to see how the different months are changing as far as the dollar amount and not just the visits too. So if you have any questions.
Yeah, Caitlin, really nice work. Thank you very much for what you're doing. Going back to the previous chart where you identified unique individuals. We've only got 4,400 or so in the database. This is almost double that. So are we confident that these 8,272 individuals are residents of Indian River County?
Yeah, so we're collecting zip codes for every single encounter, which is how we're getting the zip code chart as well. And we're verifying all of that to make sure that the zip codes are within the county.
I think you should mention that somewhere in this display, so that when somebody looks at it, they know automatically you're doing that.
Yeah, so they are all Indian River County residents. The ones in the portal, we already verify because they have to submit applications, but anyone that's not in the portal, whenever they submit their invoices, it includes their zip code for wherever the patient lives.
I just want to add, thank you, Caitlin. I just want to add to that it looks simple and it looks pretty and it's informative, but the work it took to put this together, and I really credit, Caitlin works very closely too with Shannon on this, and getting the encounter numbers is a big deal, but a bigger deal is the unique individuals. And I really have to thank them for working so closely with all the community partners, because there's no way in the world we could get this data without the collaboration of our community partners. This has been a heavy lift, and we're not done yet, but it's been a heavy lift. So, but we're grateful to have it. Thank you very much.
Thank you.
Mr. Chair, that concludes my report. Thank you.
Excellent, always excellent reports from your staff as well. Well done. Well, let's move on to some reports from funded agencies. First, Treasure Coast Community Health. Heather Miranda.
Right.
Welcome.
So, good afternoon. I'm very thankful to be able to present our semi-annual report for Treasure Coast Community Health. I do want to start out with, I haven't had the opportunity to get to know the trustees, and so I thought I would just share a little bit about myself. As most of you know, I'm the interim CEO of Treasure Coast. I've been with Treasure Coast for 3.5 years, but I actually have 27 years of public health and community health experience. I've worked with federally qualified health centers for 15 years, and I also acted as the health director when I was in Wake County, North Carolina, which is a county of 1 million people. I am trained as a registered dietitian, but I moved into operations. I have a master's degree in healthcare administration from the University of North Carolina, Chapel Hill, and a doctorate in public health leadership from the University of Illinois at Chicago. I also have acted as a co-investigator on research with Duke University in the area of obesity prevention and weight loss strategies utilizing technology. And I'm currently a co-investigator with UConn and FAU on a glucose continuous monitoring project. That's just a little bit about me. It's a mouthful.
I'm just going to say, wow.
I keep myself busy. I'm a lifelong learner as well. So as you all know, Vicky Soule resigned her position with TCCH, and we respect personnel privacy and can't share individual details. But I want everyone to know that our governing board has implemented a seamless transition plan, and our services remain uninterrupted. As I said, I'm serving in the role of interim CEO. I have been with TCCH as the executive vice president for 3.5 years. And so I'm very honored to be in that role. And our governing board is actively involved with the transition. All of our clinics and all of our services are operating normal, and our patient care remains our top priority. High quality care is key. We have experienced leadership and teams in place, keeping everything running well and perfect. And I will say that we have a steadfast commitment to ensuring high quality care and access to care for our patients. And I also want to emphasize that collaborations are extremely important to us with all of our partners, our funders, and hospitals, and that is uninterrupted. As part of the federally qualified health center recruitment process, a CEO must go through a national search. So HRSA requires that, so we are actively going to be starting that process as well. So I want to give the update. The three focus goals are expanding access to primary care and mental health services in Indian River County, expanding access to essential healthcare services for the uninsured and underinsured, and developing and implementing high-impact preventive health initiatives. So some measurable outcomes. So as many of you know, we opened our West Health Center. It opened on September 8th, and our goal was to see 7,000 new patients. What I can share with you as of yesterday, we have served a total of 2,400 unique patients in the 2.5 months that we've been open, and we've done almost 8,000 encounters. So we are busy and the site is functioning well. We have partnered with Cleveland Clinic and Healthy Start. We're using a pediatric care coordinator to help facilitate getting newborns in for services as quickly as possible at discharge. And we were able, in part due to the West opening, to eliminate our dental waiting list. We had over 2,000 individuals waiting for dental services, and we've been able to get our list down to about 100, and we have more operatories and more services available. We also have implemented a few processes. We're using something called FastPass, which allows patients to get their appointments taken care of sooner. So if someone cancels an appointment, patients who are waiting can get a text and they can get in quicker with their provider. And we're also focusing on ensuring additional functionality around communication with our patients, including prescription requests, and communicating directly with their providers. So some of the other outcomes I'd like to focus on, we've also worked hard around our initiatives with children, including kindergartners, focusing on dental and health screenings. Specifically, we work with all of the schools relative to dental screenings, but we also have a special collaboration with Dodgertown, and we've done some additional vision and dental screenings on site and been able to bring children in who needed care. We are, as I mentioned in my intro, we are currently participating with Florida Atlantic University and the University of Connecticut on a diabetes research project. This is an innovative project to monitor folks that are using the continuous glucose monitoring devices that you may have seen on people to look at their effectiveness. And we're also looking to expand provider availability through platforms, reducing wait times, improving access, and enhancing continuity of care. We did have the opportunity in the last several months to add 3 behavioral health therapists. So we have been able to reduce the overall wait time. And we have continued to launch campaigns, especially around vaccines, and encouraging patients that are 65 and older to get RSVP. And RSV, I'm sorry. Also, we've been working really hard with Cologuard, and we have an initiative to try to ensure that more people have access to getting services such as that, that maybe in the past they wouldn't have had access to. So we do know, going back to the immunizations, that unfortunately we've seen a decline in the total number of patients that want immunizations and parents that want them for their children. But we work hard to continue to educate and provide those services. We have had to decrease the overall supply on hand because we haven't been able to utilize those. And also, I wanted to mention another project that we're working on is it's something with our Epic EMR. So one of the challenges that many healthcare practices have is that patients don't show up to their appointments. And in a lot of places, you may be familiar that your provider might charge you $50 if you don't come to your doctor's appointment, or $75. Federally qualified health centers cannot do that. And so we look at ways to not punish our patients. We are actually using something called predictive analytics. We're able to run a report, and every patient has a number assigned to them, and that's the likelihood that they might not show up for their appointment. And we're taking extra care to call those patients and try to help facilitate, whether it is change their appointment, get them transportation, or cancel if that's what they would like. That's how we've leveraged our Epic system. Although West has been doing really well in terms of overall encounters, we are struggling a little bit with pediatrics. Our pediatric area has not picked up as quickly as we had hoped. We may have to consider in the future changing some of the exam rooms and using them for other services such as behavioral health or dental, or possibly family practice. I do want to note, because we do have our Oslo pediatric facility that's going to be opening up in the fall of 2026. We don't anticipate any challenges there with pediatrics because that community area is highly, has many, many children based on the data. And also that particular site, Oslo, has completely maxed out. And so we have a lot of opportunity there. Our family practice providers are fully booked, as well as our pediatric providers. And so we're very much looking forward to the opening of that facility. So some of the emerging issues, and this one is probably hot on everybody's agenda, is the ACA and the premiums that are going to go up. I checked before I got here to see what the status was, because every day it's different. So far, it's still the same. We anticipate that the premiums are going to go up for our patients. And so we are actively calling and using a new product we have, which is called Phreesia. We're going to be texting our patients to bring them in for health navigation appointments and try to get them on sliding fee scale in hospital district, because they're going to lose their coverage. And that could result in them not going to the doctor and not taking care of themselves. So I did want to talk a little bit about some transitions. Obviously, I'm a transition, I'm here. But I also want to share that we have made some changes in the last several months. Many of you know we ended our contract with the jail. We stopped our contract on September 30th, but we are still working collaboratively collaboratively with them. We are using our dental mobile unit once every 2 weeks to provide dental services on site. And we also have a grant from HRSA, our funding agency, to provide medical assisted treatment services, medication assisted treatment services on site at the jail once a week. And we are committed to that. Our grant lasts until the end of next year, and we've had a lot of success in that area. We've also made some changes. Mental health court we were administratively responsible for mental health court. We did have meetings with several partners, and we made the decision that Mental Health Collaborative would take over the mental health court. And so effective January 1st, that responsibility will be with Wes. We're very honored that he's taken that on. Additionally, we have made the decision, WeCare is going to separate from us administratively, but they will continue to collaborate with us as a partner in our facility, providing healthcare services. And we're very excited about that. I do want to say that we are focused on, I'm a data-driven person. We are focused on the numbers and we are focused on technology. We are using AI to help make it easier and more efficient for our providers. We are also looking at different tools to survey our patients, provide campaigns or information to our patients, and we're also looking at ways that we can communicate via text two-way to our patients, because right now we are not able to do that. From a funding perspective, we have, if you look at the numbers in our report, in our budget for behavioral health, dental, and medical, well, for behavioral health and dental, we expended more than 100%. For medical, we were just right at 98%. And we also, I will say that we did have money allotted for our mobile units, which our mobile units, we pulled back on those. We found that it was more essential that our providers were in our locations and that we could serve more patients there than we were serving on our mobile units. Let's see. So basically, if you look at our financials for the year, and we're looking at it from the 24-25 year because that's our fiscal year, we expended 101% of the funds provided. We served 3,999 folks, and we did about 3,999 encounters. And that's my report. Thank you. Question?
Very much. Very report, a lot of information.
Thank you.
I have some questions.
Oh, good question. I'm here.
Yeah, nice try.
Yeah.
A nice try. I stuck away. Yes, go ahead.
Okay. Well, I was looking at, was it okay for me to go ahead?
Sure.
I don't want to interrupt. I was looking at this report that the district prepares, and it shows encounters, but it doesn't show unique individuals. And when this summary down here, it does the same thing, except that under dental, it shows residents served. So is it difficult for you to monitor that?
No.
Just from my point of view, I want to know that information.
And we can get that information. So it's actually not. So when we report to HRSA, we report unique users and we report encounters. And so, yes, we can get that data. Absolutely. If it was not included in the report. Yeah.
Let me also add that the organizations were under no obligation to use the new reporting of encounters and unique patients until October 1st of this year. So some organizations decided to use that reporting tool to report on old historical data. Some did not. But just so you know, it didn't go into effect. The dashboard technically didn't go into effect, the new reporting tool, until October 1st of this year.
And just for a background on our unique users, so for the previous year, we served approximately 28,000 unique users. We're slated for this year to be about 35,000. And on average, our patients have about 3.5 visits per year, but we can definitely provide.
Is that in Indian River County?
Well, we serve
I know you do.
We are only in Indian River County. We serve people outside of the county who come to us, but the answer is our service area is Indian River County. But yes, there are people that come to us that are coming from Brevard County, from St. Lucie County and Martin County as well.
Okay. There's something we're going to need to resolve then, because we want, and at least I want, Indian River taxpayer dollars to go to Indian River County residents.
They absolutely do. They go through the application process. And so none of our folks that are outside of the county get any of the Indian River County dollar.
Okay.
Absolutely.
All right, well, I just would like to monitor that,
Yeah, absolutely.
Dawn.
We actually do check their invoice every month and look at the portal to confirm that they're active.
And then I was also, I'm sorry,
No,
you-
no, that's okay.
I was also, we keep
Go ahead.
doing it, I'm sorry.
Go ahead.
I was just, also, I thought I was going to change the subject. Maybe you want to finish that one.
I was also going to say, we do provide information to our patients during the application process, and they do understand whether they will or won't qualify based on the county of residence. So we're very strict about that. But yes, go ahead.
And how many employees and specifically how many physicians
So.
do you have in Indian River County in these facilities?
So we have a total of just over 300 employees, and we have a total of providers. And this includes, we have dental, behavioral health, medical. We have
Yeah.
about 87 different providers. They're not all full-time, but we have across.
I know
the-
one of them. is-
Yes, yes. Yes. Yeah, so 87, that was the number that I received just the other day.
Give me that number again. I've missed it.
87.
87.
Yes.
Okay, thank you.
So I had a question again regarding the mobile medical office or medical and dental. Mr. Kent gave his report, others listed the mobile medical office, but in yours, TCCH, it doesn't. Are you decreasing the utilization of
So
that service?
Thank you for asking the question. So we did not use the medical mobile significantly during this past year. We used them the previous year. We had a lot of technical issues with the heat. But the secondary issue was that we were finding that if we had the provider in a site, they could see more patients than they were seeing on the mobiles. So we made the decision to pull that back for medical. The dental mobile is solely used for the jail, so that's outside of scope. But yes, what we do use them for is outreach activities. So if we go to an event, we'll bring the unit with us. Sometimes we'll do some screenings, but we don't do any billable encounters.
Did you see any decrease in the number of encounters or new patients not having the mobile medical unit?
No, actually, we didn't. And part of that is if we look at the 28,000 to the 35,000, we did not. We did not. No problem.
I've got a couple questions. Speak to the timeline for the search. You said the board was getting ready to start it. What is the timeline for the search?
Normally the process, so they do a national search, so they have to go out to the national, we have NAC, which is our national association. We also have FAC, which is our Florida association. So we have to go out and advertise, and then they go through a recruitment and interview process, probably about 2 to 3 months before they make a final decision. My understanding is they're looking at first of the year. Obviously, the holidays is not a good time to recruit, and so that's sort of the game plan, yes.
Okay. You mentioned something about 2,000 were on your wait list for dental.
Correct.
Is that correct? And you reduced that to 100 on your
Correct.
wait list. Could you explain how in the world you did that and can serve 1,900 additional people?
So we did a couple of things. One, we opened the West facility, and
Okay.
we have 2 to 3 dentists working daily, and we have 1 to 2 hygienists. That was the first thing. The second thing was we did an update on our schedule, and we added some extra columns. And so what we did is we have extra dental assistants. And so the dentist can actually see more patients and have more chairs. And so we've actually been able to become more efficient. So we started that back in the summertime, and it was very effective. And the waiting list started to slowly decline. And then when West opened, we completely ended the wait list except for 100 people. And we have patients call in and we put them on, but they're getting in very, very quickly.
Okay. Last question. I'd love an update on your capital campaign.
Sure. I'm looking at Loretta. Loretta is our Chief Development Officer, and she is our expert on that. I'm gonna let her come up and share a
That's
little
great.
bit about that. Sorry, I didn't mean to catch you off guard.
I picked the least convenient seat to get out.
Thanks for asking that question, Carrie.
Fundraiser.
We are, we've raised $2.5 million toward our $4 million goal. We've got several six-figure asks out. And we also just applied for an appropriation through the state of Florida, one of the legislative appropriations that I think Shannon was talking about. It got quiet during the summer. Not a surprise, the snowbirds weren't here. And still we're starting to ramp things up. We've had a site visit from Johns Island Foundation. Gosh, I feel like I wrote so many grants, I can't even keep track of them anymore. But we've got a lot.
2.5 includes the districts.
Yes, it does.
Okay.
Yes, it does.
And I remember there was previous conversation around new market tax credit.
Mhm.
And that's still in process or?
No, we closed new market
You-
tax credit.
Okay.
I'm sorry, yeah.
Right.
Oh, wait.
I might have missed it, so my apologies.
You know, I think when we did it, we were just so excited that it was done.
I bet, yeah.
We decided to move on. We closed that on March 7th.
Okay, terrific.
Yes.
Thank you.
You're welcome.
Anyone else? Okay.
Oh, I'm going to try to ask my question as precisely as I can. I'm not intending to invade the board or the leadership's authority and responsibility in terms of the leadership question. My question is about just because you're a funded agency and we're stewards of the $1 million that we've made the commitment for, and leadership questions have come to me as a trustee. So I'm not asking anything about the decisions or what have you. I don't want to get into concerns about the transition of the leadership as well. Okay, so because sometimes you ask a question, it suggests you're suggesting an answer. I am not doing that.
Okay.
The transition in leadership that has occurred, are you experiencing any difficulties in meeting the capital campaign or any other areas?
No, we haven't had any.
And this question is indelicate, I'll be honest, okay? And is one that probably should be answered with the discretion of the board. Because I've been asked, and the questions are in the nature of the abruptness of the need for the transition and whether or not there were any negative issues. I'm not going to categorize any, but negative issues that necessitated a transition in leadership and whether or not you can answer that. Now, I understand you're on the spot and this is a board sort of thing, but just the viability of the organization and the importance that you guys have in our community as a steward of the $1 million and other commitments that we have, that's where the question's coming from.
No, I understand. So what I can say is we have no reason to believe that there were any issues, but we are in the process of selecting an auditor to work with us. But there is no reason to believe that there were any financial.
I appreciate that. Thank you.
No problem.
Okay, thank you, Heather.
Right, thank you.
Thank you. Really good report, Heather.
Okay. Now we would like to ask Maria Andrus to come forward and tell us a little bit about Whole Family Health Center. Welcome.
Good afternoon, trustees.
Yeah.
My name is Marie Andrus, and I have the pleasure of serving as the CEO for Whole Family Health Center. First, I want to say thank you for the continued support that the district provides to Whole Family Health Center and the people we serve. Your partnership plays a critical role in helping us meet the growing need for healthcare for uninsured residents in our community. We're also grateful to the district staff for their collaboration and assistance throughout the year. It's been a couple of years since we last provided a verbal report, so we really appreciate the opportunity to provide an update on our funding utilization for the past fiscal year, and also to share all the happenings at Whole Family Health Center. For the fiscal year 2024-2025, Whole Family utilized 99.4% of the funding awarded by the hospital district. With this support, we provided healthcare services to 3,885 residents with visits totaling 9,937. That's Indian River County residents specifically. While some individual funding categories came in slightly above budget and some slightly below, overall, we believe these results reflect strong stewardship of the funds entrusted to us. Most importantly, the funding allowed us to deliver vital access to primary care, mental health care, and lab and pharmacy services to our Vero Beach Health Centers, at our Vero Beach Health Centers, and through our mobile medical office. Since you have a detailed written report, I won't go through every funding category unless there are questions. Instead, I'd like to spend time highlighting broader whole family health center initiatives and offer a broad picture of our organization. Many of you may be familiar with our origins, but for those who are not, Whole Family Health Center was founded nearly 30 years ago as an HIV research and treatment center by Dr. Gerald Perrone, who's an internist and infectious disease specialist. At that time, Dr. Perrone was the only infectious disease specialist on the Treasure Coast treating HIV and AIDS patients. Dr. Perrone continues to serve as our chief medical officer. Over time, the organization expanded to provide primary care, and in late 2017, we achieved the designation as an FQHC lookalike. This designation brings important compliance and quality requirements under HRSA, the Health Resources and Services Administration. But unlike full FQHCs, the lookalike designation does not include federal grant funding to subsidize care for uninsured and underinsured patients. That financial responsibility rests with us as part of our nonprofit mission to care for all who seek our services. To give you a sense of how much we've grown, in 2018, Whole Family had 50 employees and cared for 4,300 patients. This year, in 2025, our 200 dedicated staff members will care for 20,000 patients during 70,000 visits. We will make 45,000 referrals to specialists. We will answer more than 225,000 phone calls. And from our 2 in-house pharmacies, we will fill 135,000 prescriptions and deliver 30% of those prescriptions to patients' homes free of charge. Our business model is unique in that the 340B pharmacy program generates the largest share of our revenue, close to 3/4. Visits themselves operate at a loss and represent about 25% of our revenue. Grants, donations, and special funding, including your support, make up the remaining 5%. The margins we generate from the 340B pharmacy program are required to be reinvested back into our mission to serve everyone, and especially the uninsured, underinsured, and low-income individuals. This program is what makes it possible for us to fulfill our mission and maintain access to high-quality care. However, the 340B pharmacy program is facing significant erosion. For example, pharmaceutical manufacturers' restrictions that began in 2020 have increasingly limited 340B pricing at contracted pharmacies and decreased our revenue from that source. The Inflation Reduction Act's drug price negotiation beginning January 2026 on 10 high-margin medications will further reduce 340B revenue opportunities. And the proposed 340B rebate model introduces additional downward pressure as well as cash flow challenges. These changes directly threaten the revenue that supports Whole Family's care for the most vulnerable members of our community. Meanwhile, the population of Indian River County continues to grow, and with it, the number of individuals seeking medical care. To expand access, Whole Family Health Center acquired a 15,000 square foot medical building in Vero Beach late last year. This year, we launched our first ever capital campaign, which is a 5-year, $5 million capital campaign to help offset acquisition costs and remodel the first 7,500 square feet of the building. I'm pleased to report that we've raised approximately $1.2 million to date in gifts and pledges. We're proud of that progress, but we recognize that we still have a long way to go. Earlier this year, I submitted a request to the hospital district for $1 million in support over our 5-year campaign, similar to an award previously made to another nonprofit conducting a capital campaign. The request was tabled pending hospital district development of a policy for capital funding requests. If I understand correctly, capital funding may be addressed in your current recently discussed purchasing and procurement of goods and services policy. And if so, we do hope the district will reconsider our capital request, as your support would directly benefit Indian River County residents seeking care at Whole Family Health Center. We recognize our responsibility to maximize every dollar and to strengthen our sustainability. We are actively working to diversify revenue and improve operational efficiency. Recent steps include pursuing additional state and national grants. Thus far, we've successfully secured new cancer screening grants and an HIV and STI screening and prevention funding, which totals more than $1 million. We've implemented AI tools, artificial intelligence, to improve provider efficiency, including an AI scribe tool that integrates with our EHR and an AI tool for managing clinical inboxes. These are ongoing efforts to streamline workflows while preserving high-quality care, strong patient satisfaction, and support for provider well-being to reduce fatigue and burnout. In closing, I want to thank you so very much for your continued support of Whole Family Health Center. Because of your partnership, we're able to ensure that the very best care is available to every member of our community, regardless of their circumstances. At Whole Family Health Center, when we come to work, we bring our hearts with us. Our entire team serves with gratitude, grace, and appreciation. Thank you very much.
Thank you very much, Marie. Are there questions? Alan Jones.
Yeah. A couple, incidentally, congratulations on what you're doing. I think you all make a difference in our community and Treasure Coast as well, of course. But thank you for what you're doing. But I was looking at the report that I have, and you do have unique individuals served on it, but it shows 3,982. But you said 20,000 you'd serve. So I'm just trying to reconcile those two numbers. The 3,982 is just for district eligible?
Yes, yes. The total of 20,000 patients served would be across our entire organization. And as you know, we have a service in St. Lucie County, but I'm only reporting on the district funding. And so the report that you have in front of you is just district funded uninsured patients.
Okay,
But
yeah, thank you.
overall, we still do serve 20,000 patients in the Treasure
And the
Coast.
200 employees you have, is that Indian River County or also St. Lucie?
The entire organization.
Yeah, and what about physicians? How many physicians and medical providers do you have out of that?
Specifically, medical overall, we have a total of 42 providers,
And
medical and.
do they go
behavioral
back
health.
and forth between counties, or are some of them here and some of them there? Or-
It depends on what the specialty is. We have
Yeah.
individuals who have specialty in infectious disease that may work in both counties, but for the most part, most of them are in their individual locations, either in Vero Beach or Fort Pierce.
Well, how many in Vero Beach?
I would say that there are probably 24, a little bit better than 50%. About 52% of our patients are in Indian River County.
Okay. Yeah, thanks.
You're welcome.
Other questions?
Yes, if I may. You referenced in your report, and I'd been following it loosely. There have been a lot of changes in that 340B program, which is significant. You were your language was there were some downward pressure. I don't begin to fully understand the impact. It's an entirely new structure. Can you talk a little bit more about that and how significant that pressure is going to be to the bottom line?
It's difficult.
Or is it too soon to know? I mean,
It's difficult to measure at this time.
okay.
Our director of pharmacy does an excellent job trying to estimate what that may be, along with our CFO, who happens to be with us. I have a couple of our senior team members with us, and I always appreciate their support because we work together well as a team. Our director of pharmacy has an important job, obviously. She's done an excellent job over the past few years, taking our pharmacy capture rate, our internal capture rate, from about a third to 50%. And that's very significant because I think some people think that it's easier for us to generate revenue because we care for infectious disease patients. But the reality is of those 20,000 patients, less than 600 are the immunocompromised patients, and not all of them get their medications from our pharmacy. So we really try to work to give our patients the best experience at our pharmacies. And we're open on Saturdays as well to accommodate them. And we do deliveries and those sorts of things. But going back to the pressure, the Inflation Reduction Act will start with 10 high margin medications like Eliquis, for instance, would be one of the higher margin medications that will directly impact us. So it may help Medicare patients, but because the manufacturers are restricted on how much they can sell it for to everyone, the amount that we could purchase it at a discount may still be the same, but the reimbursement from all the insurers is going to be less. So of course, the 340B program is wonderful in that those who are uninsured and cannot afford their medications, if they're patients of whole family, they're always going to receive their medications. Those who are insured and use our pharmacies is where we can generate revenue, and that's what supports, our mission. So that Inflation Reduction Act is really going to be especially challenging because all the 10 medications are high margin medications. And that's just the first year. And then there's the next year is another 10 or 15 and another one in, 2028. So something else that's come up is called the 340B rebate model. So essentially what's happening there is we currently can purchase our medications from the manufacturers at a discount to start with. The 340B rebate model for certain medications, especially those first 10 in the Inflation Reduction Act, will require us to purchase the medications at wholesale acquisition price, which is essentially the same as what a CVS or Walgreens would pay. And then the manufacturers will supposedly within 10 days give us the difference and the discount. And what they're supposed to be doing in those 10 days is making sure that there aren't duplicate discounts, okay? So our assessment of all of this is basically a way for the manufacturers, the pharmaceutical industry, to limit the 340B program overall and their exposure. And it's to erode the program. And I don't see it as any other way, to be quite honest. It started in 2020 during COVID, the first restrictions, and little by little, it's about what they are trying to do to limit the program. So there is a lot of uncertainty. It could be $500,000 less in revenue to us next year. It could be a little bit less than that. It could be a little bit more. The 340B rebate model really just came about as a draft program in around October. And yet they were able to, they have big lobbyists and so forth. They were able to push it through so that the program is starting January 1st. We have platforms we have to be prepared for to submit information. It's very, very challenging. But, we'll comply with absolutely everything that we must. But the cash flow issue is about the rebate model.
Thank you. Again, you read a couple articles and with this particular issue, you came to mind. So I felt I wanted to see, and bottom line is we don't really know, but it's not a good outlook.
No, and our board has gotten updates directly from our director of pharmacy. And, we're basically trying to strategize on how we can overcome these challenges.
Thank you.
Question, Marie, may be difficult, but I have a friend in Detroit who helped initiate 9 different federally qualified healthcare groups. There's multiple healthcare groups. Of course, that's a large city of 900,000 people. So the question here is, being a lookalike and with your financial challenges, what's your opportunity to become a fully qualified?
Yes. So that's also very challenging. It's completely dependent upon the federal government announcing a new access point grant opportunity. Currently, that's the absolute only way that a lookalike can become a fully funded center. So the last time there was actually an opportunity last year in 2024 where we submitted an application. And at that time, HRSA told us, we don't have the funding in place yet, but we expect it to come. So we want every, FQHC and lookalike who's interested in this expansion, the new access point, to apply. And of course, we spent a lot of time and effort putting what we thought was an excellent application together. And we were even adding a location because for lookalike, the qualifications are a little bit different. Essentially, all the centers that you already run become part of your new access point because we aren't currently funded. Anyway, the bottom line was, things changed, administration changed, the funding never materialized. So that opportunity ended really before it started. And the last time there was an opportunity was in 2019. So that was 5 years prior. We applied at that time. It's very competitive. There were only 77 awards and over 500 applicants. We came in at number 98, so we scored extremely well, but that did not get us funding, and that's.
When you do that, is it for a certain area? Like I know you're in St. Lucie County too, and do they have a federally qualified healthcare provider there as well?
Yes. Yes, there's a full FQHC in that county as well. Yes.
So if you were, it's sort of like certificate of need kind of scenario, I suppose, is what they look at. So if you were to get it, does that mean then you have to share, TCCH has to share federal funding with you, or is there additional funding?
It's additional funding. Yeah, I got that clarified from the project officer from HRSA when we applied in 2019, because I know that question came up then, do we have to share funds with other full FQHCs? And the answer is no. They get to keep theirs. you know, they have to sort of reapply every 3 years. And when they do, we give them a letter of support. We have to do our renewal of designation, it's called, as a lookalike. We don't get the federal grant funds, but we still have to reapply to continue our designation. But there is, there's no real way for us to say, well, here's the certificate of need, even though obviously, you know, the patients that we're serving, I believe that they're getting good quality care and service from us. I know that 95% of our patients rate us as very good to excellent, and we get very good patient satisfaction services. So that, so we don't, the answer is no.
Okay, thank you.
Everyone keeps their own, and it's their new funds.
Okay, any other questions? Thank you very much for excellent presentation.
Thank you. Happy holidays to everyone.
Yes. Okay, we'll go on to unfinished business, and Frank, do you want to lead that, or Jennifer discussing?
I'm going to lead on this one. I don't know why it has Frank's name there. And also have Dr. Mackett kind of explain what he's been appointed to. So Dr. Mackett, as I understand it, was recently asked to join the, I'm sorry, did I jump something? I did.
Yeah.
That's okay. That's okay. So
You can
Yeah.
do
That
that.
confused me when you said.
no,
Frank.
that's okay. That's okay. So thank you, Mr. Chair. We're going to have VCOM has been in town. And so we've had a chance to meet with the leadership at Edward Via College of Osteopathic Medicine 2 days ago. And then yesterday sat down. And one of the things the main thing we were focused on is looking at if, from the prior meetings, you know, we were tasked to sit with VCOM and update what the timelines, milestones are. And we did just that. Ideally, it would have been great if we had a chance to get this done earlier, but they came into town when they came into town. So we tried to hash out, talk through some of these items last night. And I'm going to ask Dana to talk through that.
Absolutely. All right. So as Frank had just mentioned, from a historical perspective, we have had the lease with VCOM since 2024. There were the number of deliverables that were in the original lease that were in section 4A through E. In July of this past summer, there was concern that potentially one of the deliverables coming up at the end of September wasn't going to be met. So we did send a notice to VCOM back in July asking for additional reassurance of completing the deliverable that was due on September 30th. At that point, there was correspondence back and forth. We did not get full completion of that deliverable. So then in October, the board had decided to allow an extension of time for VCOM to be able to either cure that default or negotiate other milestones for Section 4 to be deemed as new deliverables under the contract. So that extension expires January 9th. So the idea was, and unfortunately, as Frank said, VCOM was here. So it was a positive that they were able to look through the human services building. They have their plans. They met with contractors, et cetera. But because this was all last night, we were able to sit down with them. It is kind of a quick turn of what the proposed terms are. So everything on the document I sent last night, the new section 4A through E in the First Amendment, are the proposed terms for deliverables based upon the discussion that we did have with Dr. Rollins and Dr. Matt Cannon from VCOM last night. And that's where, if we look at the First Amendment that was provided, it is only Section 4 of the lease that is intended to be updated. No other portions of the original lease will be altered at all with this amendment. So there would only be updates to Section 4, which are those key milestones and deliverables. There is a provision in that amendment, which is number 3, effective amendment on the original lease, that does solidify that in there, just in case there is question. So as you'll see in the new proposed Section 4, it does read as though it's more about what's going on with the construction. In the prior version of the lease, there were some more, I would say, terms that said facilitate creation of a medical school. Things like that, where it's allowed a flexibility as to what VCOM was doing. What they said to us last night was, we're committed to get this done. We have the plans, we have the developers. They're ready to start actually getting plans approved, which you'll see that was what was the proposed new Section 4A by March 31st, 2026. So in a few months from now. The second is they do plan on then moving forward with submitting all of their permit applications by June 30th. They were talking about actually getting the permits approved because of engineering, et cetera. We wanted to make sure there was a little bit of flexibility there so it's not going to just lay flat if there's some reason for the permit to just be extended, but it's still in and active would be the big idea. Then we have the phases. So this was based on the physical review of the building that they performed on Tuesday. So they have decided how it is they'd want to build out all 3 floors of the building. And as you see in section C through E, they've separated it out in 3 separate phases. We did want to define the term complete. So as you see at the footnote later on page 2, still in section 4, which would be the new proposed section 4, complete as used herein is defined as the remodel and construction being complete for the purposes of the intended use. So that means that individuals that are attending the medical school could actually go in and use those offices, simulation center, et cetera. So that is what we have gone through here. Happy to answer any questions, open for discussion based upon what the trustees feel as though this is enough to really show that VCOM is invested. And if there's any other discussion or proposed portions to add here, obviously we would do that as well. There is some back and forth that would then have to be done. So if there are changes to the language here, which is the availability to do, we would just then need to have an extension of the current extension. So we are up till January 9th now, and because of the holiday, to get something done and turned around in that timeframe would likely require an additional extension.
Thank you very much.
Yes.
Dana. I have a question. So I understand that on the original lease option agreement, section 4, all those go away, all of the, particularly like establishing a full accredited medical school, first through 4 years by October 1st, 2030, which is only 3 years away. That doesn't exist anymore.
Correct. The idea would be the new section 4 would supersede anything in that prior section 4. So again, if there are items in there, and if it is something that is the board's desire to make sure that that is in the agreement, that can be put back in. This is all in the discussion of where VCOM wanted to show actual measurable things over time. So instead of something that is 3 years out, or perhaps that would be something to say it would be 2030, 2031, depending on the time frame, they wanted to show inch step measures where we have something in 3 months, something in 6 months, something in 1 year.
I think as we discussed, the intent, as I see it, is for them to show for the legislature that they are actually have something other than a building, but actually moving forward with that. And as I mentioned early, it seemed to me that we need a timeline for them to deliver on this. For example, a year from now, December of 26, to know that they have actually got the approval through the legislature to move ahead, because that's the challenge as I see it.
I would agree. And my question was going to be, not having the whole lease in front of me, was whether or not this removes some of the allegations in terms of the actual technical development of a school and the timetable that we had established. I can appreciate the complexity and, the difficulties they're having in getting things done. I think it's a mistake for us to go forward with just this, because our commitment is to have them lease the building for a specified purpose within a particular time frame. I think the fact that we've come to them and said, hey, we're running into some deadlines, let's work with it, has demonstrated flexibility on our part. I would invite them to give us a realistic timetable to accomplish those things in addition to these physical plant improvements, so that we have some accountability. Otherwise, without that, conceivably they could decide to fix it up and sublease it to a medical practice or what, I don't know. But I think without that degree of commitment from them, there's something missing for us.
And I do just want to bring up, just for clarity, so back when the original lease was executed, there is an addendum. So that was back in 2024. And that first addendum does say that the parties to the Human Services Building lease with option to purchase, and it lists the district and VCOM, specifically acknowledge if Florida state law prohibits the establishment of medical education for VCOM students within the state of Florida, the agreement will be considered null and void. So that is also another portion of the original document that talks to what they're able to do with the legislature. So it would just be another portion in the thought process of what we'd want to potentially touch to update.
Okay. So the obligation still remains, if I've heard you correctly. The timetable does not.
So they still are pushing forward. So let me take that back a second. In the new proposed amendment, there is a timetable, but most of that, as you see in what I sent last night, has to do with the creation and construction of the building. There isn't as much hung dependent explicitly in this proposed draft on getting the accreditation.
Right. Again, I prefer that we have some accountability on the accreditation front.
Fine. So with the accreditation, if they do not get it and they have this lease with us and they are fixing the building up accordingly, because I am assuming it's going to take some time for them to get this accreditation, if they are even able to. What then? I'm sorry, I don't have, again, the whole lease in front of me or
Sure.
whatever. So is there a signability in the contract?
So the way that the original contract reads right now is they do have that requirement to have an accredited facility. And then the portion that would be the consequence if they do not is that they no longer get to exercise their option to purchase. So they would be a lessor, they could theoretically be in breach, the district could have them pay rent, et cetera. So there are a number of different ways that can be addressed if they did not get accreditation in the original lease.
I would, TCCH, and if Chuck Cunningham was in the room, could speak to allowing 6 months to get through the county.
What happened?
Would be perceived, I think, by many in the community to be, well,
I can speak.
fine,
to that.
fine, yeah, fine.
I can speak to that too. How long?
Yeah.
Planning and zoning.
Find your own language. But I recognize why it's here. It's a goal. I wouldn't be surprised at all if they get hung up there, and we'll be at a point where we're going to need to just recognize the reality of how quickly you get cooperation to be able to move forward.
Absolutely. And that's where in subsection B in the proposed amendment, it does say submit permit application.
Oh, okay.
So completely understanding where you're coming from.
Yeah.
It could take a while, especially
Right.
for certain.
But you can't go to
portions of the
C
building.
if B
Yes.
doesn't get finished. And
Yes, but they still would then be on the hook for C, which is completing
Right.
phase one by December 31st,
yeah.
2026.
I mean, we know the reality,
Yes.
and I'm fine. I mean, this does part of what we want to do going forward, I think, but I'm in alignment with other thoughts.
Dr. Mackett?
Yeah, thank you, Dana, and thank you, Frank, for your hard work on this quick turn. Again, without having the full lease in front of us, please refresh my memory and educate me if there's any change in this proposal for the financial obligations that they had.
Yes, so the current lease, section 4E, has that $1 million per fiscal year requirement for a total of the $5 million. As of right now, the discussion was they'd be making those capital contributions, which you can see by the construction within the 2-year timeframe. They had given us an estimate of what they believe the construction to cost. So that was a portion in the discussion of, we didn't have to explicitly call that out year by year if they stuck to their construction. There are different ways to do that, but that was a proposed item to take out and then replace with actually going through pretty much every 6 months of having the construction phases completed.
So, like trustee Westcott, I think I would like a little more detail on that. Because if phase one only included painting,
Right.
that's far different than a $1 million capital commitment.
Yes, so phase one is intended to be comprised of offices, conference rooms, and completion of the simulation center. And that is in the agreement. We can definitely get whether it's plans upon approval and have those incorporated, if we do want that extra detail. So each phase does have in here in parentheticals what they intend to do for each floor or phase.
Yeah, I would prefer that included a projected cost estimate, expenditure estimate, et cetera.
I have a structural comment that might just help us as we navigate this. Maybe perhaps if we can extend some time to do further work on this, hearing the comments tonight, we do an amendment and restatement of the lease. So we don't have a lease and an amendment. It's one document. I think that would make everybody feel better with reading it. It's not too many sections that we're amending, which is why we did an amendment, but it sometimes can just be easier to read it as one document versus the pieces.
I agree.
And again, remember, this is just their proposal.
Correct.
We anticipated presenting the proposal. We know there's going to be a lot of further discussion. This was just their proposal. There wasn't negotiation. It was just their proposal.
Correct.
So you get a sense of our concerns, so that's good.
Yep, sorry.
And the time frame is we need to do this quickly. We've got-
Not necessarily.
We just
Not
need to
necessarily.
extend the extension we gave them because it only goes till about January 9th and the board doesn't
Correct.
meet again before that time. So that was why we wanted to bring it for you tonight for consideration and then we can navigate as we need to.
Would an additional 60 days beyond the 9th be sufficient or excessive?
I don't
Either.
think we would take any longer than we needed to be able to complete this unfinished business for you.
I move that we provide an additional 60-day extension to address realignment of the lease to current circumstances.
Second.
Got a motion on the floor. Is there any further discussion? Any public comment related to this, since this is a motion? Seeing none, all those in favor?
Aye.
Opposed? Motion carries. Thank you very much, Dana, for the very report, Jenna. Okay, we can go now, I think, Frank, to new business. Dr. Matt.
I still have one more unfinished
Oh.
business matter, which is, this is a simpler one. It's just the purchasing and procurement of goods and services
get-
policy that that is under unfinished business, I believe, that we discussed yesterday, and we took into consideration the requests for the edits and changes that the trustees wanted. Those have been made. And so that is just simply before you again to approve the purchasing and procurement of goods and services policy.
Thank you. So just in review, we've approved the reserve fund policy yesterday. And the internal audit is approved with some recommendations. This is the only one left that needs approval.
The third policy, we're going to look at again in January. We didn't approve the third one. We only approved the reserve policy. This one was set for approval tonight, subject to some very minor changes that we made after yesterday's discussion.
Okay, so up for discussion is the purchasing and procurement of goods and services.
That's correct. Okay. Just looking for a motion to approve that.
We need a motion to approve that.
I move approval.
Second. Okay, the motion's been made and seconded. Any further discussion? Any public comment? Yes, ma'am. We come to the microphone and identify yourself. Thank you.
My name is Dasha Baker, and I have been a resident here for, I was in Vero Beach High School in 1983, since I've been here a long time. And I want to thank you all for your respect for communication of healthcare matters. These are very serious concerns, and televising them with the television has really been helpful to me. And I didn't get any response back when I tried to send in communication about the last televised meeting. So I was wondering, and I did send to Kate Boss my communication, and she said she would forward it to you all, and I haven't heard back from you all, is the first concern. And the concern that I was trying to raise about it was that I was concerned about, that I received that the update for November 5th, 2025, Florida Health Chart shows that lung cancer is now the leading cause of death in Indian River County, Florida, as of 2024.
And we're only calling for public comment right now on this specific issue. We will call for general public comment at the end of the meeting under
Okay, I
item
thought you
9.
ended.
So if this is not related to the policies and procedures that we're adopting for purchasing procurement of goods, then
Oh, okay.
we'll just ask
I thought
you
were
to
asking
reserve
general
your
comments.
public comment until we get to that point in the agenda.
Okay, thank you.
But you'll have an opportunity. Thank you.
Clarification.
Okay, so
Let's call the motion.
yes.
All those in favor of the revised purchasing and procurement of goods and services policy? Say
Aye.
Aye.
Opposed? None, the policy change is approved.
Thank you. Okay, sorry, I jumped ahead on this one a minute ago. That little unfinished business just got past me. So Dr. Mackett has been appointed to the Cleveland Clinic Indian River Hospital's Safety, Quality, and Patient Experiences Council. And he asked me to review with my team whether or not we thought that this was any sort of a conflict of interest for him to serve on that council while he's also serving as a elected district trustee. I reviewed it, as did Dana and our third attorney, Lynn, and none of us felt that it was at all any sort of a conflict of interest for him to serve as he's been asked to serve. So we just wanted to bring it before you to clarify that we were aware of it, we did vet it, and that was our recommendation to him so that he can serve if he so chooses to do so. And trustees have served on the patient, it was called something different, I believe, at the prior hospital, but they have served on the patient, I want to say care advocacy committees in the past.
But he's not serving with his district trustee. hat
There's no
on.
other, good, thank you for mentioning that. No, it's nothing. He is the sole trustee appointed to this council.
And it is, to further clarify, not an ex officio position.
Advisory?
Correct.
Voting member. If there's votes. I don't know if there's.
Correct.
It's similar to like the integrity committee or something.
Employee of Cleveland Clinic Indian River Hospital.
Partners.
I am not. I am a member of the medical staff. I am not an employee.
Okay, so he is serving as a trustee on this council.
I don't know how they've asked you to serve. You're serving as an individual,
physician.
correct?
He's serving as a physician,
This is an
not,
appointment.
this has nothing to
He's
do.
personally being appointed. It has nothing to do with the hospital district. It's
Thank
not a
you.
district
Okay.
council or committee. He just is a trustee. So that's why we're discussing the potential for a conflict. Hospital is appointing you,
Okay,
correct,
the
Dr.
Cleveland
Mackett?
Clinic has asked you to be on this committee,
Yes.
and you're just bringing it up because.
And for further clarity, I have not accepted it pending the recommendations of legal counsel and my colleagues' view on whether or not it is a material conflict.
And this is a safety, quality, and patient experience council.
Yes, it is.
I love the idea you would be on that.
Absolutely.
Patient experience is important.
And I don't see it as a conflict. I think
So
it'd be
we're
helpful.
being informed this doesn't require any action.
No action. My recommendation is.
I
he
certainly
can
don't have any
serve.
objection to it.
Just wanted you to have situational awareness to it, and that we had vetted it and that there's not a
Right.
perceived conflict of interest for him to serve as well as being a trustee.
Will we be able to ask him questions about it?
As long as it doesn't require him to disclose information that would potentially violate HIPAA, that's the only thing I can think about.
Good, okay.
And I will clarify that with the council as well.
You know, they meet twice a week.
Fourth Wednesday of each month.
Oh, okay.
I assume Dr. Cooney will never be at any of those meetings
No,
Is that
he will
right?
not. The only person that's appointed,
because you serve on the board. So I just,
Right.
oh, no, there will not be any other trustees present.
yeah.
All right, so there's no other action. I just wanted to bring that before you. Other business.
Thank you, Judith.
Is there any other business? As we
I know it's running late. I have a couple of quick things. One, predicated on discussion yesterday, and since you've got this month's expense report in front of you, expect an email from Kate asking you to give some consideration to what you consider to be a substantially funded program. You're keying in on the discussion because of policy. Just, you've got a document, look and see. I'm throwing one thing out. Alan, I think you said you thought anybody over 2 million. Well, we've got just a couple. So, which is fine. I mean, we've got to work through it. I'm just giving you a heads up. The other is, just so that it's mentioned, I know Frank and Jenny and I think maybe 3 or 4 of us were at the ribbon cutting for the King and Day Stubbs labor and delivery. I mean, those suites are
Beautiful.
it's an amazing space. And it was noticed. And I said to Carrie, nice to see you.
That was it.
And that's all I can say to you.
Probably a big fan.
And I walked away. No, there certainly wasn't any inappropriate discussion, but I wanted to just say they've done a whale of a job. King and Day stepped up in a very significant way to help support the work, and seeing it was really amazing, and will be one of the key factors, I think, that's going to continue to show why Indian River County moms and dads should be utilizing all of the facilities that are there. It's the data we've talked about, but the facilities now are just top drawer and worth mentioning. Good job, Cleveland Clinic.
Thank you, Michael. Any other new business?
Can I make a comment?
Yes.
Dr. Cooney, this is your last meeting as chair of the district for 2025. I just want to recognize that and thank you for taking that on.
Thank you very much.
You're here.
Thank you, Bill.
Well done.
Okay, now it's time for public comment. Forward. And you don't have to introduce yourself if you'd like.
Okay, I'm Dr. Helen Baker. I talked with Kate Voss, and is she here?
She left ill. She left ill.
She left. Okay, so I sent her an email about my public comment, and I wanted to give it to you. And I want to thank you for your respect for communication with our healthcare community. And I have a concern about how lung cancer is now the leading cause of death. And with November Awareness Month, we didn't have any community health action about that. And I attended different national, the Mental Health America National Conference and the National Community Health Conferences. And they all recommend having blood pressure screenings with the Library with Hearts program with mental health screenings, and encourage doing that with community health events. So I thought maybe with this meeting series that you have, we could have blood pressure monitoring with mental screenings for people to learn how to get connected and work together for community health.
Thank you. One of our goals is preventive care, and certainly blood pressure screening is an important part of that.
Yeah.
Frank, maybe you could clarify, we're still discussing what role the district have as far as referring specific people to specific doctors and so on. Do we have a role in that? Do we have a role in recommending blood pressure screening? I think we do, but.
Yeah, thank you, ma'am. You know, prevention is, I believe, the future of medicine. The transition from preventive care to sick care to preventive care. And I see that as the future of healthcare delivery. And prevention is a big priority of ours. The district we don't perform, ma'am, the staff that we have is right here. We don't perform any clinical or paraclinical services. We don't do anything like that. That's not part of any operational aspect of the district. And I'm not saying it has to be that way, but I appreciate the comment. It was thoughtful. Thank you.
And also with the links, like I didn't get any response back, and also with the website links, some of them are insecure. And so how do we facilitate communication so that I can get my comments heard and without having to go in to the meeting here?
Can you just explain? I'm just curious. So you sent an email? Is that what happened?
Yeah, to Kate Voss.
Okay. Okay.
And I didn't get a response
The
back.
records custodian. maybe?
As records custodian, perhaps? Okay. Yeah, let,
through
let,
links.
Were you asking for information or you just wanted to express yourself to the trustees through her?
I said that didn't get any response back. And also the
I under-
Treasure Coast,
Right,
both
what
the
I'm,
hospital district as well as the Treasure Coast Community Health, I sent in.
I'm trying to find out the nature of your communication. In other words, when you sent the email, were you asking for information? Were you trying to share your thoughts with the trustees? In other words, what I want to try to find out,
About the
I mean-
Lung Cancer Awareness Month.
just, right. Okay, I didn't hear.
Of lung cancer awareness.
I understand that. But you were trying to share information with me as a trustee and the other trustees?
Correct.
Okay, and you didn't get a response saying, thank you, I've sent it to the trustees? That's your observation for us right now, is that right?
Correct.
Okay, thank you.
As well as the
Thank you.
Treasure Coast Community Health, when I sent them requests for like having healthcare data tables that are, as they were talking about the idea of two-way communication with AI to facilitate communication. That still needs to happen.
Right, I'm just trying to make sure that I leave the meeting with a real full understanding of what you're informing us of and asking.
Well, I'm
Thank
asking
you.
about Lung Cancer
Thank you.
Awareness Month. I'm asking about blood pressure screenings with the Libraries with Hearts program, with mental health screenings, with the community health events like these. And we could set up a booth, a community health kiosk where people can get that and just have an informal check-in about our, physical and mental health together as modeling that for our community.
Ma'am, I will say that many of the services you just talked about, especially the combination of primary care and mental health, that's all this is being done in our community. Blood pressure screenings, all that. These things are being done. They're not being done by the district, but these things are being done.
Well, I'm saying that they are being done, but Lung Cancer Awareness Month was not being observed, and having community health events where people can learn how to do that together could help facilitate that according to the science.
Thank you, ma'am. Thank you.
Okay.
Thank you.
Thanks for your comments and for staying through the
Thank you.
long meeting for your
Thank you.
presentation.
Blessings.
Is there any other public comment? Anything online that, oh, no, they don't have it here. Okay, I'll call the meeting adjourned. Thank you very much.
Thank you all.